Thank you for the invitation to present the histopathological aspect of thyroid gland malignancies. At the beginning, I would like to let you know that the information included in this presentation is mainly based on the guidelines and recommendations provided by the College of American Pathologists. I also had the opportunity to attend the endocrine session of the European Congress of Pathology, which took place a couple of months ago in Belgrade, and I will be very happy to share with you some very interesting new data according to our topic. The histopathology report consists of two major parts: the macroscopic examination, which is the process by which specimens are inspected with the naked eye to obtain diagnostic information, and the microscopic examination, which is examination of the tissue under the microscope. At the macroscopic examination, or otherwise the gross examination, the pathologist should record the type of the procedure, the specimen integrity, the specimen size and weight. Also, if a tumor-like lesion or multiple tumor-like lesions are being identified, their location and size should also be recorded. This is a gross photo of a total thyroidectomy specimen. For those that are not familiar, this is the right lobe, this is the left lobe, and this is the isthmus. Before we start taking sections of our specimens, we should paint it with black ink, and this will help us later on to evaluate with accuracy the status of the surgical margins, as well as the presence of extrathyroidal extension. Then we cut each lobe into very thin parallel sections, and we try to identify any suspicious lesion. This white lesion here is suspicious to be malignant and should be submitted for further microscopic examination into these cassettes. The microscopic examination, here we will analyze the histologic type, and we will also say a few things about the significance of the presence of extrathyroidal extension, of the positive surgical margin status, and of a positive lymph node, cervical lymph nodes. But before we start with the malignancies, let's have a look at the normal appearing thyroid parenchyma. You can see its architecture into follicles. Inside the follicles, you can recognize this pink material. It is called colloid, and it is where thyroid hormones T3 and T4 are stored. Special immunostains are required to identify the C cells, the calcitonin-producing cells, that can be found either as a part of the follicle or interstitially. There are two major categories of thyroid carcinomas: those that are derived from the follicular cell and those that are derived from the calcitonin-producing cells. The only representative of the second category is the medullary carcinoma. The follicular the tumors that are derived from the follicular cell are subdivided into a well-differentiated category, a poorly differentiated category, and an anaplastic or undifferentiated one. The papillary carcinoma, which constitutes the vast majority of thyroid malignancies, belongs to the well-differentiated category, as well the follicular carcinoma does. There are also some unusual or rare tumors, for example, the development of a marginal lymphoma in a background of a Hashimoto thyroiditis. We will start with the papillary carcinoma. Here we have two typical cases. There are both typical cases of papillary thyroid carcinoma. In the first one, you can recognize well-developed papillary structures. The second one lacks papillary structures, but you can see a follicular growth pattern component. You may recognize the resemblance of this structure here with the normal appearing thyroid parenchyma. You can see inside here there is a colloid material, but both two cases are typical cases of thyroid papillary carcinoma because they have a common denominator. And this common denominator are the nuclear features. Nuclear features is the gold standard to diagnose a papillary thyroid carcinoma. It's all about nuclear features. There is no need to demonstrate papillary structure, so you can see that the name is a misnomer. Also, unlike other organs, like other carcinomas in other organs, there is no need to demonstrate invasion of the adjacent parenchyma. A totally encapsulated tumor in thyroid can be a carcinoma. Here we have in details the criteria for those nuclear features. You can see here you can see the chromatin clearing in these nuclei here. They look very similar with the eyes of this little girl here, coming from an old American comic strip, which later on became the famous musical with Annie. That's why we call them Orphan Annie eye. Also, you can see that this nucleus here looks like a coffin bean because of its nuclear grooves. The cytoplasmic inclusion into the nucleus, it's a very strong diagnostic criterion to establish a diagnosis of a papillary thyroid carcinoma, but it's not a very common one. And of course, the elongation, the overlapping, and variation in size and shapes are also very important features. This slide here shows us the variants of papillary thyroid carcinoma. Of course, there is a usual, classic, conventional variant with the typical well-developed papillary structures, but we have to remember that this variant is nearly always associated with a follicular growth pattern component. The microcarcinoma, it's usually an incidental finding measuring less or equal to 1 centimeter. The follicular variant that lacks well-developed papillary structure, and it is composed entirely or almost entirely of follicles. The solid variant, the diffuse sclerosing variant, the tall cell, the columnar cell, and other very rare variants. We will begin with the microcarcinoma. As I have already said, it is defined by WHO as an incidental papillary thyroid carcinoma measuring less or equal to 1 centimeter. It is believed to be found in 1/3 of autopsy cases and also in 1/4 of thyroidectomies performed for other reasons. This curve here shows us the huge increase of thyroid cancer incidence since 1990s. However, you can see that thyroid malignancies still remain a very rare cause of death. And here comes a question. Do improvements in ultrasound techniques allow us only to detect more indolent tumors? And if you ask me, I will probably say yes, because microcarcinoma is a very common finding, generally with an excellent prognosis. That's why we have to find a way to recognize those tumors with a possible host behavior. For this reason, a combined histologic molecular scoring scheme has been proposed recently. This scoring scheme evaluates the BRAF V600E mutation status and also 3 histological parameters: the subcapsular location, the peri-initial tumoral fibrosis, and the multifocality. Even this scoring scheme has not been validated yet. The documentation of these morphologic parameters is recommended because it may be useful in clinical management decisions. Here we have 2 photos, microphotos coming from this paper. In the first one, you can recognize the subcapsular location of the tumor. You can see that the outer surface is painted with black ink. And the second microphoto shows us the extensive intratumoral fibrosis. It's true that over 90% of papillary thyroid carcinomas are indolent tumors cured with thyroidectomy and radioactive iodine, but can we identify the aggressive ones? Again, the slide with the variants of papillary thyroid carcinoma. You can see here that there are 3 variants that correlate with the worst prognosis. The tall cell variant, the diffuse sclerosing variant, and the columnar cell variant. We will say some more things in details for the tall cell variant, because there are some very interesting new data for this variant of papillary thyroid carcinoma. Tall cell variant is associated with resistance to radioactive iodine and a worse prognosis. However, there are some issues need to be solved. The height of these neoplastic cells should be 2 or 3 times the width. And how many tall cells are required to impact patients' prognosis? According to the WHO published in 2004, half of the tumor has to have this morphology to establish such a diagnosis. But there are very recently published papers that have shown that only 10% of tall cells are enough to influence a patient's outcome. Also, this paper here have shown that this morphology is commonly seen in BRAF V600E positive tumors. BRAF V600E mutation is the most common frequent alteration in papillary thyroid carcinoma. It is frequently found in classic and tall cell morphology and seems to be associated with aggressive behavior and a high propensity for extrathyroidal extension. Even this marker is hotly debated because there are several studies that actually fail to show that this marker is an independent prognostic factor. A positive status may help in management decisions. This is a case coming from my laboratory. You can see the tall cell morphology of the neoplastic cells in a background of typical nuclear papillary thyroid carcinoma nuclear features. And as we had expected, this was a positive tumor for BRAF mutations using immunohistochemical techniques. To conclude with the papillary thyroid carcinoma, let's have a look at the parameters that are associated with an adverse prognosis. We all know that younger patients tend to have a better prognosis, and of course the gender, the tumor size, and the multicentricity impact prognosis. Also, the microscopic variants, as we have already said, the tall cell, the columnar cell, and the diffuse sclerosing variant tend to have an adverse prognosis. The presence of extrathyroidal extension is a very important parameter. Also, tumors with infiltrating with finger-like markings correlate with the worse prognosis than those that are totally encapsulated or have pushing margins. The presence of even a small focus of poorly differentiated or anaplastic morphology can impact prognosis and should be recorded in the histopathology report. And of course, the presence of distant metastases. All these data should be recorded and should be provided by the histopathology report. This diagram here shows us once again how important are the nuclear features in thyroid gland malignancies. In the presence of those features, then the diagnosis is always a papillary carcinoma. In the absence of those features, if we have an encapsulated lesion, then we have to check for capsular or vascular invasion. In the absence of capsular or vascular invasion, then we have a benign lesion. But in the presence of capsular or vascular invasion, then the diagnosis is a follicular carcinoma. To diagnose a follicular thyroid carcinoma, we have to exclude, by definition, a papillary thyroid carcinoma and to demonstrate capsular or vascular invasion. It is usually a solitary thyroid mass. It has a higher incidence in iodine deficient areas, and so it is a very rare tumor nowadays in contrast to the first half of the last century. Here is a gross photo and a micro photo of a typical follicular adenoma. You can recognize the intact capsule, fibrous capsule. And this is a case of a follicular carcinoma with a full thickness invasion of the capsule in a mushroom-like fashion. Follicular thyroid carcinoma is subdivided into minimally invasive cases and in widely invasive cases. Just have in mind that cases with only capsular but no vascular invasion tends to have an excellent prognosis. Since the diagnosis of malignancy depends entirely on the demonstration of capsular and/or vascular invasion, one should be very strict with this criteria. Submission for microscopy of the entire capsule of a follicular adenoma is mandatory. But there is also a gray zone, and here comes the borderline issue. It is a fact that even experts in thyroid gland pathology, sometimes there are some cases with questionable both nuclear features and questionable capsular invasion. For this reason, the Chernobyl pathology group has proposed about a decade ago 3 new entities. The diagnosis of a well-differentiated tumor of uncertain malignant potential can be made for cases with both questionable nuclear features and capsular invasion. The term follicular tumor of uncertain malignant potential can be made for cases with absence of nuclear features and questionable capsular invasion. And the diagnosis of a well-differentiated carcinoma, not otherwise specified into a papillary or a follicular type, can be made for cases with questionable nuclear features but an apparent capsular invasion. Here I'm showing you once again this slide with the variants of papillary thyroid carcinoma, because there are some very interesting new data. According to one variant of papillary thyroid carcinoma, the encapsulated follicular variant of papillary thyroid carcinoma that correlates with an excellent prognosis, and this is something not very compatible with the diagnosis of a carcinoma. So investigators have made some second thoughts about the classification of this variant of papillary thyroid carcinoma. This neoplasm frequently comes with questionable nuclear features. That's why it is the most famous representative of the borderline category. It is also the most frequent reason for consults in thyroid pathology. There is a great inter-observer variability. A lot of pathologists used to diagnose this type of neoplasia as a well-differentiated tumor of unknown malignant potential. And it is true that American pathologists make more malignant diagnoses due to the litigation climate in medical practice in their country. But there are some this paper here, published in Human Pathology earlier this year, shows us that for this type of neoplasia, the invasion, rather than the presence of nuclear features, correlate with patient's outcome. Also, the molecular biology of this variant of papillary thyroid carcinoma has more similarities with the follicular carcinoma than the papillary carcinoma. Even BRAF mutations are different in these two types of tumors, the papillary carcinoma and its variant. So we have a molecular profile closer to the follicular thyroid carcinoma than to papillary thyroid carcinoma. So it seems that it is probably a distinct type of tumor with a highly favorable outcome. It might progress if not removed, but a conservative treatment is recommended. There is no need for total thyroidectomy and radioactive iodine. This photo here is taken from the endocrine session of the European Congress of Pathology and says that there is a new recommended terminology for this type of neoplasia. For this variant of papillary thyroid carcinoma, a new terminology, the non-invasive follicular thyroid neoplasm with papillary-like nuclear features, is recommended. And if this will be widely accepted, then this variant of papillary thyroid carcinoma will not be a carcinoma anymore. We have analyzed in detail the well-differentiated carcinomas. Let's have a brief look at the poorly differentiated category and the anaplastic carcinoma. Poorly differentiated carcinoma is also poorly defined. It has histological features and biological behavior between well-differentiated and undifferentiated carcinomas. Please remember that even a small focus of poorly differentiated carcinoma in an otherwise well-differentiated tumor can impact prognosis. And here is a case of poorly differentiated carcinoma. You can see that there is a lack of papillary structure, a lack of follicles. You can see that there is a nested insular or solid histological growth pattern. The undifferentiated or anaplastic carcinoma is mainly seen in elderly patients, has a very high mortality rate, and a mean survival of 6 months. Extrathyroidal extension, it's usually present at presentation. It is a highly malignant tumor composed of an admixture of pleomorphic giant cells, spindle cells, or epithelioid cells, and special immunohistochemical stains are always necessary to confirm the epithelial origin of this neoplasm, because this morphology can refer to a carcinoma, to a sarcoma, to a melanoma, or even to lymphoma. Let's go further to the, let's move on to the rest of the points. Extrathyroidal extension refers to the involvement of the perithyroidal tissues as the infiltration of skeletal muscle, sizable vascular structures, and nerves. There are two types: the one that is established clinically, the extensive one, and the one that is established microscopically, the minimal one. It is believed to be found in 1/4 of cases, and it is an indicator of greater likelihood of distant metastasis and poor prognosis. The presence of cervical lymph node metastases does not seem to worsen the prognosis. It has an adverse prognostic influence only in the older age group and in case with a large size metastatic focus, with or without extranodal extension. And finally, the surgical margins is the evaluation of the relationship of the tumor to the inked surface of the thyroid specimen. Although information on margin status is requested, there is no data to date on the prognostic value of closed margins. Unlike hollow organs of the gastrointestinal system, tumors at the margin does not correlate with an incomplete excision. That's why the residual tumor, the R classification, may only be applicable to anaplastic carcinoma.